All right, good morning, everyone. I'm Dr. James Griffin. It's my distinct pleasure to introduce today's first session and our fourth keynote speaker for the 2023 mid-year seminar. I'm grateful to be joined today by Dr. Robert Isaac. Dr. Isaac is a professor of anesthesiology at the University of North Carolina at Chapel Hill. He completed his medical school training at Nova Southeastern College of Osteopathic Medicine and his anesthesiology residency training at Vanderbilt University. Currently, he serves a variety of leadership roles at UNC, including being the director of the liver transplant and vascular anesthesia team, anesthesiology medical director for Enhanced Recovery After Surgery program at UNC, associate residency program director, and the director of anesthesiology simulation program and residency curriculum. Additionally, he serves as chair of the American Board of Anesthesiology OSCE exam committee, and he is an OR board examiner. Dr. Isaac will be speaking today on To Infinity and Beyond Challenges of Cases During Commercial Flights and Interplanetary Spaceflight. Please join me in welcoming Dr. Isaac.
All right. Thank you, Dr. Griffin, for that really kind introduction, and thank you all for having me here in Chicago. I'm really grateful to be here. I've actually come to speak at the AOCA a few times before, and the last time I was invited to the mid-year seminar was right when COVID hit, and so I was presenting virtual. It was kind of a new thing to present virtual, and so I didn't get to be here in Chicago, so I'm really happy to be here this time. And the talk that I'm going to be giving to you guys this morning, I hope is an interesting talk, but I hope it's a fun talk. It's a great way to start out, I think, a final day of a conference and get you guys engaged and interested, and I hope to have some time at the end if you have any questions about the topics that I'm going to talk about. So as a disclosure, I have no financial disclosures to make, but I do want to disclose that I'm not a pilot. I'm not an astronaut either, and the topics that I'm talking about are coming about because I've had some in-flight emergencies that I've dealt with before, and I found some interesting pieces of facts that occurred during these flights, and then doing some additional research found out a lot more information that I'd like to share with you. And so what I hope to do is review some common emergencies that might occur during commercial flights, as well as provide resources that would be available to you when you're on the flight so that you can deal with these emergencies in an efficient and capable manner. I won't talk about how to deal with a snake on a plane. I'm going to be talking about more common emergencies. So if that happens, you're in your own element. I'm not really sure what to do there. And I'm also going to talk about the medical challenges that might occur if we're ever in an interplanetary space flight. So some of you might think that that is complete future and science fiction, but I would argue, and you'll see here later on, that the likelihood that somebody who we're working with right now might actually take care of a patient in space is really pretty significant. I think there is a likelihood. Unfortunately, I won't tell you how to do what Matt Damon did, which was to grow his own potatoes using his own materials in the movie Martian. If anybody ever seen Martian, I'm going to help you understand other ways to take care of it. So the information that you're going to hopefully take away from this presentation, it might be extremely relevant. Many of you are probably going to be flying home today to wherever you live and practice, and you might actually use this information before you even get home to save someone's life. By show of hands, anybody ever been on a flight where there's been an in-flight emergency that's occurred? All right, so a good number of you. And of you folks who have been on a flight, did anybody respond to that in-flight emergency to help provide some care? All right, excellent. So this is not a unrealistic situation. So this might be very relevant. It might happen like in a few hours to some of you. This might also be the most irrelevant talk you ever hear in the rest of your life. You may not use any of this information at any point in your career, but I still think it's really cool to talk about and really cool to think about some of these things and to kind of challenge your mind as to how you might deal with this situation. So how did I become interested in this topic? So I mentioned that I've had in-flight emergencies, but it really dates back to 2008. I was a senior resident at Vanderbilt, and I was giving a case conference for our senior residents. And I was asked to open up the anesthesiology journal for that month and pick out an article that I was interested in to present at our case conference. So the authors of this article, some of you might recognize some of these names up here, some prominent names in anesthesiology, wrote about in-flight medical emergencies and what to do in these situations. And I'm just going to pull out a couple quotes that they had in the article. But they said that providing assistance to an airline passenger requires flexibility and crew resource management. Does that sound familiar to anybody? Does that sound something like what we might do in the operating room? Crisis resource management, being flexible. Anybody have to be flexible where they work right now? Maybe get an add-on case or a switch of case. This really is right in our wheelhouse. And an anesthesiologist needs to be able to manage complicated, unpredictable situations. When you hear that bell ring, you never know in the airline when that bell is going to go off. You never know in the operating room when that bell is going to go off. And you need to be able to be a qualified person and a qualified physician in order to help those patients on air flights. So I always like to start my talks by giving you guys the take-home points, and then I'll end with the take-home points as well. So if you come in late or if you have to leave early, these are the things that I hope to review and really emphasize. So medical emergencies are relatively common. They occur in about 1 in 600 flights. If there was a medical condition that happened in 1 in 600 patients, I bet you all would study it and learn about it. Like if we said malignant hyperthermia was 1 in 600, we'd all be very aware of it. We're well aware of malignant hyperthermia, and it's a far lower incidence. So it's pretty common. The most common emergencies are syncope, near syncope, followed by GI and respiratory issues. One of the things that people are most concerned about when it comes to in-flight emergencies is the legality of it. And fortunately, in 1998, Congress enacted the American Medical Assistance Act, which basically provides coverage, in a sense, to help physicians caring for patients in medical emergencies. When you're caring for somebody on a flight who's having an emergency, you are covered, assuming that you are not negligent or derelict in your duties. The FAA mandates that all commercial flights have a minimum medical kit, and we'll go through that. And I want to emphasize the requirement is quite minimum. Some airlines go above the minimum, but many stick at the minimum. Space exploration, going out into space. This is a rapidly expanding area, and it requires careful medical planning. You can't just jump up into space and not be prepared for what might occur. And things like telemedicine, ultrasound, having an appropriate supply kit and the appropriate personnel will really help people get through the flight of space carefully. So, you're flying home from this conference. We could probably turn the volume down a little bit for the next ones. That was a little bit more dramatic than I would thought about in my mind how it was going to be. So you're flying home from this great seminar, and you are thinking about all the information that you learned here about how to manage pulmonary hypertension and right ventricular failure and all these great things. And all of a sudden, while you're kicked back, relaxing in your seat, you hear this bell go over. And overhead you hear...
Excuse me, sir. I'm sorry I have to wake you. You a doctor?
That's right.
We have some passengers that are very sick. Could you come take a look at them?
Yes, of course.
I know all of us are probably flying home with a stethoscope on our ears, just like Leslie Nelson here. And you hear that dreaded call overhead, and they say, is there a doctor on board, or is there a medical provider on board? And so as I mentioned just a moment ago, this is not an uncommon situation. This occurs 1 in 600 flights, so it occurs around the globe about 100 times a day. That's crazy, right? 100 times a day this is occurring. In the United States, and in Canada, and in the UK, so first world countries, if you will, there's no legal obligation for us as healthcare providers to jump in these situations. We have an ethical obligation. I would suspect that if you have the skills and the knowledge to care for a patient, you probably should jump up and raise your hand. I know the 2 times that I have, my wife has done that for me on my behalf. She's raised my hand. She literally raised my hand up. And so, yeah, you might want to consider doing it, but you're not absolutely required. If you're worried about the legal aspects, as I mentioned, there's a Medical Protection Act from Congress that was put together in 1998. And I'll talk more in detail about that here in just a few minutes. In certain countries in Europe and in Australia, there is a legal requirement. Some of these are the countries that take the philosophy that they pay for medical school for folks, and it's a type of system where they're public institutions, and they think it's a legal obligation that if you were supplied with your financial assistance that you should also help in these emergencies. I want to point out that there's no legal requirement to present your credentials. This was a hot topic, so to speak, about 5 or 6 years ago in the New York Times and the Washington Post, where there was a few physicians who were on an airplane. They weren't dressed like doctors coming back on a flight from the Bahamas, and they questioned whether or not these folks were physicians. Even one person who showed her medical license at the time, they questioned whether she was a physician. She happened to be a physician who was working at a Harvard hospital as an associate level professor with a lot of experience. But there's no legal requirement for that. You don't have to worry about carrying your medical license in your pocket or anything like that. So when you're in an in-flight emergency, you're going to have some limitations. There's going to be limited access potentially to other people to rely upon, other equipment. And the reason you're being called upon is because the stewards and the stewardesses, they have some degree of medical training, but their degree of medical training is quite limited. It's really more of the BLS level of resuscitation or medical care. And what they're asking for is somebody with a higher level of training to assist in these circumstances. Now, many airlines, they're not required to, but most of the regular airlines, Delta, United, etc., they partner with these organizations that are ground-based medical support that you can call in the middle of the flight. You can say, hey, I've got this lady, she's 67 years old, she's got this going on. What do you think we should do? And these are real-time advice to help you understand what you could do to manage the situation. It's kind of like on the M-House hotline in a way. But they can also help you understand whether or not diversion would be necessary in this situation. But it's not required to have these contracts in place by the FAA. And as I mentioned, there is a medical kit on board, but these medical kits are regulated minimums by the FAA, and many airlines will exceed these minimums, but several of them will meet the minimums exactly where they are. I don't know if anybody flew Spirit Airlines. I've never flown Spirit, but I understand that they have some limitations to what's on board, and I've heard that their kit, for instance, is only meeting the FAA minimum and not meeting the maximum requirement. All right, so what are some of these challenges that you might have? So the space is limited, right? You barely have enough space for your knees, let alone enough space for putting a patient down and doing a procedure or taking care of them. The setting is unfamiliar. Right, we all complain about getting sent on to MRI to do an anesthetic. This is a very unfamiliar setting for most of us. The equipment that we have on board, we've established, is quite limited. Like for instance, they might have IV start kits. They might have one 22 gauge IV, so don't blow it. You know, you got one shot. Go for the big juicy vein. And then we also are going to have biases, right? We all have bias towards our own medical profession. The cardiologist is going to think they're having an MI. The pulmonologist is going to think it's a COPD exacerbation. We're going to think, something airway related potentially. And so try to not be locked into your own cognitive bias in these situations. All right, so we had that overhead call for a medical provider on board. So you go to evaluate the patient. You see she's sleepy. She's minimally responsive. You tap on her shoulder. What could be happening? What are some of the things that might occur on a commercial flight? So, most commonly, the number one thing is syncope. And so I'm going to go through several slides here. This comes from a great article in JAMA that was published about 3 or 4 years ago that puts together these nice slides essentially with all of the potential causes and how you would diagnose or initially evaluate, and then how you might manage the patient over time. So syncope is about 30% or near syncope of the in-flight emergencies. Those of you who raised your hand, did everybody have syncope on their flight? Is that what you guys had? Several of you, yeah, not uncommon at all. So there's several causes. You want to evaluate the patient. Are they pale and diaphoretic? Might be a vagal issue. Are they having chest pain or dyspnea? Maybe this is a cardiac issue. They could be short of breath, and it might be pulmonary. They might be having a stroke, some stroke-related symptoms. Maybe they're hypoglycemic. They got to the airport late. They didn't get a snack. The service didn't happen on board. My flight here, there was too much turbulence, so they didn't bring out the drink cart. I bet somebody got hypoglycemic on that flight. So what do you do? The first thing you should do is you should probably take the patient or the passenger and lie them flat on the floor if you have space to do that. And you might consider raising their legs as well to sort of auto-transfuse them, if you will. If you have oxygen on the plane, which you should, and you can easily apply it, go ahead and put some oxygen on them. If it's just a near syncopal episode, probably laying them flat and lifting the legs will get it done. And if they're hypoglycemic, trying to give them some sugar-containing solution might work. Ironically, my brother's an ER physician, and when I told him, I gave this talk once before, and when I told him, I called him on the phone, I was like, hey, I'm going to give this talk, and he's like, oh my God, that just happened to me. I'm in St. Louis. It just happened to me on my flight earlier this morning. And the person was hypoglycemic, and he gave them orange juice, and that's really what fixed them in that situation. But if no improvement is occurring in this patient, you definitely should contact that ground-based medical support and try to get additional information as to how to take care of this situation. The second most common thing is going to be a GI issue. It could be a GI issue that is in various types of extents or timing, so you probably want to get a little bit of a short history to understand what's going on with the patient. Are they having nausea? Are they vomiting? Are they having diarrhea? That's a very different situation. This is crazy. I actually had a friend who had a flight canceled 2 weeks ago because the flight before the patient had such bad diarrhea they had to evacuate the plane and they couldn't use the plane anymore. So that could be a really bad situation and might honestly lead to diversion. They were coming back from a tropical area where they were concerned about the cause of the diarrhea. Diarrhea can, or the GI symptoms could include some bleeding, and of course there could be abdominal pain. So depending on what the circumstances might dictate what you want to do. If they're having nausea, there are some antiemetics sometimes on board on these planes that you might consider using. But you also want to try to hydrate them, just like you would a patient in the PACU. You might want to give them some glucose-containing solutions as well. Or IV fluids. If they're having dyspepsia, there may be some antacids, or if they don't have it in the supply kit, likely somebody on board has some Tums on them that you can try to use as well. And if they do have diarrhea, in general, we don't think as a medical community giving antidiarrheals is really the best thing for patient care. In this circumstance, it probably is a good thing to do. You want to try to limit the symptoms at least while they're on board so that you can get them to their destination. If they're having severe abdominal pain and they're having blood in their bodily fluids, this is a situation where you definitely want to contact ground-based support to try to get some additional recommendations on how to proceed. Respiratory is the third most common cause, but it's only about 10% of medical emergencies that occur on board. It's really important to get a history from the patient and try to understand things like, were they scuba diving on this trip when they, hopefully no one was scuba diving here today in Chicago, but depending on where you're flying from, they might have gone scuba diving. If they have swelling, then that might lead you down a different pathway to think something along the lines of maybe a PE or pulmonary embolism. Are they having infectious symptoms? You might want to quarantine them if that's the case. There are pulse oximetries on board many of these airplane flights. Are the little portable ones that you go on your finger. And if a patient has an oxygen saturation of less than 95%, that's when you probably want to put on oxygen. The oxygen that you're going to have is going to be somewhat limited, so you really need to be careful about how you crank the oxygen up. Like when we take a patient to the PACU, you crank it up to 12 liters or 16 liters or whatever. You want to be a little bit more careful because your supply could run down quickly. Patients might have bronchospasm. There should be a beta-2 agonist on board like albuterol. There is also epinephrine in severe bronchospastic situations. And if a patient doesn't recover, again, you want to contact ground-based support. If they don't recover quite quickly, you want to contact ground-based support to get some additional recommendations on how to proceed. Cardiovascular, this is one of the kind of feared things that we hope doesn't happen on board, and it happens about 7% of the time for all emergencies. So again, getting a history from your patient, have they had a previous MI or a recent stent placed, and they maybe stopped their anticoagulation. You can, on some planes, they have the ability to get a 12-lead EKG. A lot of people are wearing Apple Watches, and you can also get a single lead EKG right on the Apple Watch as well. And try to see what's going on. If you suspect they're having acute coronary syndrome, they're having an acute MI right on the plane, they have signs of chest pain, dyspnea, and maybe jaw pain. If they're having arrhythmia, you might feel a thready pulse, or their pulse might be irregular in quality. This might also just be dyspepsia, a GI illness. And so you want to think about that if that might be a suspected cause, because if you have a cardiovascular symptoms, you're going to think high on your list of things to do might be to divert the plane. And you'd hate to divert the plane just for some dyspepsia, but if that's the case, that's okay. So what should you do? If you have acute coronary syndrome, they have aspirin on board, they have nitroglycerin as well. You can continue to give nitroglycerin until the patient starts to stabilize. If they're just having respiratory symptoms, maybe oxygen is the way to go. As we mentioned before on the previous slide, lots of different potential things there. We've talked about dyspepsia already, that there's going to be antacids. And the symptoms, if they're persistent, you give a nitroglycerin, they continue to have chest pain, you really want to contact ground-based support to get some more help. Strokes, about 5% of the time, are the emergency that's occurring. This is a common theme. You want to get a history from the patient, try to figure out what's going on, try to understand the timing and onset of all their symptoms. Is it motor? Is it sensory? And if they're having a stroke, you might also see some speech disturbances or some facial droops like you see in this patient in this picture. The management is a little bit more limited, right? I mean, in general, the limits to stroke care are a lot further than in cardiac care. And so if you can give oxygen, it might be worth putting on some oxygen on the patient. And if they're having ongoing neurological symptoms, you should definitely contact the ground-based support to get some more help on how to proceed in this situation. Seizures occur about 5% of the in-flight emergencies as well. And if you forgot how seizures present for like tonic-clonic, you can look over and there's a phase 1 and phase 2 in the cartoon on the left-hand side. But if you identify that a patient's having seizures, the first thing that you should probably do is put them on their side and try to protect their airway. If they're on an airplane, there's a good chance they might have a full belly, and you want to make sure that they don't aspirate when they're having the seizure. So you put them on their side, try to assess their vital signs if possible. If they have an ongoing seizure and they have a epileptic diagnosis and they take seizure medications, try to get their seizure medications and administer them to them right there if possible. But oftentimes it's not possible, so you might have to give some sort of benzodiazepine that they have on board, usually in the medical kit. And then if the seizure is ongoing and you can't stop it, this is a circumstance where diversion might be necessary, but contacting ground-based support, again, is important. Trauma, this occurs a similar rate of time, about 5% of the time. And it can range from open wounds to closed wounds and including active bleeding. So of course you need to assess the patient and assess if they have any neurological signs. If they're having neurological signs and changes from this trauma, then that might be a circumstance for diversion if you think that there might be a head bleed going on. Injuries happen from falling luggage. I saw this happen just a couple of months ago. A little old lady was getting her big old suitcase out and it just fell right on top of the guy sitting underneath him. Fortunately, he didn't have a bad injury, but he really could have gotten injured badly if it didn't hit him in the wrong spot. So active bleeding, put some direct pressure right on the wound, try to stop the bleeding if possible. If it's having an ongoing, try to fashion a tourniquet, maybe using a belt or a jacket of some sort if a belt is not going to fit that area. And if you have a long bone fracture or some sort of joint injury, you might want to create some sort of splint of sorts. And there's a variety of different materials you can use, including magazines, to help create a splint. Psychiatric symptoms and substance abuse symptoms occur a little bit smaller percentage time, about 3 or 4% of the time. And really what you want to try to do is de-escalate the situation, build a little rapport with the patient if possible. This might be a really difficult circumstance to do. And if they're missing their psych medicines, you want to talk to whoever they're traveling with and try to make sure that they've taken their medications if possible. Verbal de-escalation may or may not be effective. If that's the case, then you might have a combative patient or passenger on board. All of the airlines have protocols to follow in these circumstances, and includes all the way to the point of actually restraining the patient or the passenger in their chair. This is a guy on a flight in Russia pre-war who had a little too much vodka on a flight and got a little bit rowdy, and so they actually had to restrain him using cellophane to his chair. You might have people who have substance abuse disorders and they might be withdrawing as well. And so depending on the type of substance that they're used to using and how long it's been since they've taken it, they might have a variety of different mental status changes or vital signs changes. If they've got normal vital signs and no respiratory compromise, really just observation only, but they might have more dangerous things like they might have ingested an opioid accidentally. We all know that opioids are finding their way into substances that they shouldn't, and so we should all be on the lookout for that. So if that's the case, there is naloxone or Narcan on board. on these planes that you can give to the patient. If you think it's alcohol ingestion, well, you're not going to really reverse the alcohol. Rather, you're going to just support them from the dehydration that they might be having. If they're an alcoholic and they're withdrawing from it, maybe a benzodiazepine might be what you want to use. Stimulants, they're going to be agitated, altered, tachycardic, and you might want to do some things to try to help them, like hydrate them and really just observe them and put them in a safe place. Allergic reactions, this is a small percentage of situations, but this is not all that dissimilar from what you would do for somebody who had an allergic reaction in the operating room in terms of finding out if these are systemic or localized reactions. If it's a localized reaction, diphenhydramine is probably okay if it's just skin irritation or mucous membrane. But if it's more systemic issues like bronchospasm and vital signs changes, using epinephrine. There is EpiPens on board. If you place that IV, you can use intravenous epinephrine as well. Obstetric emergencies. This is the one that I pray never happens to me on an airline. And it could be quite frightening. I've heard about these. I don't know anyone personally who's had to deal with it, but it's about 1% of in-flight emergencies. So basically that means that there's going to be someone across the globe today that's going to have an obstetric emergency on an airline. And this is why you're not supposed to fly late in pregnancy. But you want to do a detailed history, do a physical exam if you can to kind of see what is the actual emergency that's occurring to help guide you. If it's vaginal bleeding, expectant management is all it's needed at this point. But if you suspect that the person is in labor, depending on what stage of labor, you might want to glove up and get ready to deliver. But if it's more in preterm labor, if it's third trimester, you might want to give them some IV fluids, put them on their side. If they are laying supine and they're getting hypotensive, you want to use a little bit of uterine displacement. Lastly, this is the most dread. Anybody ever had a cardiac arrest on an airplane with them? No. I had a friend who was flying to Thailand and he was over the Indian Ocean when this happened. So it's quite frightening. But this is not all that dissimilar from ACLS in the field that would occur. So you want to check for a pulse and breathing. If you don't feel a pulse, no signs of life, then you're starting CPR. Since we're airway experts and we should know how to provide bag mask ventilation, you do want to do CPR that includes some bag mask ventilation at a 30-to-2 ratio. If someone not in this room is on the flight, someone who's not a good airway expert, they may just do chest compression only resuscitation in this situation. There is an AED on board. It should be applied. If it says to deliver a shock, then you deliver a shock, and then you resume CPR. If there's no response to the initial resuscitation and the AED, that's when you place the IV and start giving IV epinephrine. So just a slight difference from an in-hospital arrest, but more like an out-of-hospital arrest. And you definitely should rule out some of the causes that might be going on here. There might be a pneumothorax from the air pressure changes, a variety of different reasons that somebody could have a cardiac arrest. And then, of course, you need to contact your ground-based support. All right, that was a lot. So let's move on a little bit. Let's divert our attention to talking about airplane diversion. So
You better tell the captain we've got to land as soon as we can. This woman has to be gotten to a hospital.
A hospital? What is it?
It's a big building with patients, but that's not important right now. Tell the captain I must speak to him.
Certainly.
they don't make movies like Airplane anymore, do they? It's they could never make Airplane in this day and age anymore. But airplane diversion. So diverting an airplane sounds pretty simple. Oh my gosh, this patient has belly pain, let's divert the airplane. It's quite complicated. It's way more complicated than just the medical aspects of things. So there are medical issues like, is the patient's condition appropriate to divert for? Is the timing such that landing the plane now would make a difference in their outcome, or could we wait? If we land a plane, are we going to have more supplies available on the ground to treat this issue? Like if they're hypoglycemic, you've got orange juice on board, you don't need to land an airplane for that. And are there actually going to be time savings when you consider if you land the airplane in a rural area, let's say in the middle of, I don't know, North Dakota, are they going to have access to the issues that, or to the resources that you need, as opposed to just continuing on to Seattle for another 45 minutes? There are operational issues. Weather is a big consideration. I mean, we've all been impacted by weather for travel, and landing an airplane right now when you're in a bad weather condition, if you're flying over it, is not easy. Fuel load, this is an interesting thing to think about. If you're taking a flight from New York to San Francisco, they've got thousands of gallons of gas on board. And if somebody starts having chest pain going over New Jersey, you have too much fuel on board to just land right away in New Jersey. You have to dump all that fuel, which is not a simple thing to do either, and it's very costly. And does the airport that you're planning to go to have the capacity to take your airplane? So lots of small airports around the country don't have long enough runways to land the size plane that you might be on. So you might be flying over a place that's got an airport, but they can't take you. You're going to crash the plane if you land on that runway. So not a simple decision to make. So you're on board and you're looking at the medical supply kit and you're pulling it down. This one of the first things that I do when I get on a plane is I always now look for where is this supply kit. And sometimes you see it in these little tiny cabinets. It's like this big of a cabinet overhead compartment, and you know there's not a lot in that when you see it in a tiny cabinet. So the left-hand column, this is two different charts, and on the left side of the screen are equipment, on the right-hand side of the screen are medications. For each of these charts, the left-hand column is what the FAA requires, and then the right column is what you might find in some of these different kits. And so I tried to color code it. I'm just going to kind of go through it relatively quickly, but you see that there's lots of different airway devices that you might find on board and some additional things. You will find a mask of 3 different sizes and oral airways, but you may or may not find an endotracheal tube or laryngoscope on board. You'll have some tools to do some maneuvers to patients, things like tape and IV catheter sets. As I mentioned, there's might be a limitation to how much you have, but at least you might have some. And the additional contents might include a scalpel or umbilical cord tape. You'll have some diagnostic options like a blood pressure monitor and some stethoscopes. You might also have a glucometer or a pulse oximetry, not required. And there'll be a few things to do some treatments with as well, to do some dressings or to put on some clips or some tourniquets, but those are really not required. Those are the additional contents. As far as medications go, there are various types of medications to treat allergic reactions of various concentrations. You have epinephrine and antihistamines, but you might have some other types of antihistamines and allergic reaction treatments on board. There'll be some cardiovascular medications. The most basic things include nitroglycerin and epinephrine and atropine, but you might have other stuff like digoxin or calcium or even Lasix. There'll be some respiratory medications, very minimal. Epinephrine could probably also be highlighted here as well, but you'll have a bronchodilator and you'll have some dexamethasone. There are some GI medicines. These are kind of optional medicines. They're not required by the FAA to have these GI medicines. There will be some pain medications as well. Some of the more basic things include aspirin, but more advanced things might include some ibuprofen or even morphine. I guess ibuprofen is not an advanced thing, but some more advanced things would be like morphine. And there's a few miscellaneous medications as well, some dextrose-containing solutions, Ativan, as well as Haldol for the patients who might be having some psychiatric symptoms. The Aviation Medical Assistance Act, as I mentioned, this came out in 1998 from Congress, and these were put in place to protect us as healthcare providers in an emergency. They protect us from medical emergencies, not for medical non-emergency situations. So it's not really defined what a medical emergency is, but you need to be able to justify that in your mind that this is an emergency that you're responding to. You don't have to be asked to provide assistance. Some of these cases where people have been given hard time, it happened to the passenger next to them. They're like, oh my God, look, he's having, chest pain. I'm going to just start caring for him. You don't have to have the magical ding above in order to start providing medical care. This is a really, really important point. This does not give you legal authority over the airplane or the crew. You can recommend diversion, but the diversion decision is not up to you, it's up to the crew. So if a patient doesn't get diverted, the reason that's also important is if you don't divert and the patient has a bad outcome, it's not your fault per se. Okay, so you can't be held liable for that. And it doesn't make you responsible for the patient if there's harm as well, because the airline did not have all the equipment on board. So if somebody's having an issue on board that in a hospital you would have treated quite easily, but you don't have that equipment on board, this is also not your responsibility, and so you're protected from that. But your legal obligations, as I mentioned, are not completely absolved. You still have to act as a physician, as a nurse, as you would in your normal practice, and not do something that's completely negligent in this situation. So what should you do in this situation? You probably should, this is a suggested algorithm. There's also a great review article in New England Journal of Medicine that talks about these types of situations. You should first go introduce yourself and state your medical qualifications quite briefly. Hi, I'm Rob Isaac. I'm an anesthesiologist. I'm going to try to help you. Ask the patient if you can treat. Do you mind if I help take care of you for a moment? I know this is a tough situation. Maybe ask their family member if they're not able to provide sort of verbal consent, if you will. Ask for the medical equipment kit. This is all kind of happening simultaneously. You might need to use a language interpreter depending on where you're flying from or to, or even in the United States. You might not have a person who's speaking the same language and you might want to use an interpreter. Maybe it's a family member. It might also be the ground-based support. But think about privacy. This is going to be the most interesting thing happening on the plane, right? The other 100 heads are all going to be turning and looking. So think about when you're going to do certain things to the patient. Let's say you're going to take off a portion of their clothing in order to do a procedure or to listen to them. Just try to consider the privacy in that situation. You should take a brief but appropriate history and physical exam, try to get some vital signs, and treat within your scope of practice. For us, I think we have a pretty broad scope of practice. For some other folks who are more ancillary members of the medical health team, they may be out of their scope of practice and they shouldn't be doing certain things. You can recommend diversion based upon what's going on with the patient on the flight, and usually the most critical situations require diversion. And you should talk to these ground-based support crews as much as possible. They're there to help you. They're not competitors, they're your help. And provide assistance until you can hand off care. So if you have a patient who has chest pain and they think it's an MI, and you're going to divert them to the hospital here in Chicago, continue to care for them until you hit the ground and the EMS providers can now take over. And document. This sounds simple, but we often forget this. Write it down on your iPhone in a little note or on a back of a napkin. Just have something, because what will likely happen is that they'll call you from the airline in a couple days and ask you, hey, so what happened on the board? Tell me about it. And you want to be able to reference back so that you protect yourself, but also you can provide all the information that you can. One other just tip, don't take any payment. If they say, here is a free airline, excuse me, here's a free trip to Hawaii or something like that, don't accept the payment. It puts you in a more litigious situation. It may look kind of bad to outsiders if there's a bad outcome. Just act as an altruistic person. If they want to move you to a nicer seat, maybe if you were a center seat and you get a window seat, I think that's fine. But don't take any cash payments or any prizes or anything. So, excuse me. So this happens quite frequently, as I mentioned. This is a great study that was in New England Journal that looked at about 5 years worth of 3 years worth over 6 airlines, some domestic, some international, and tried to quantify what's happening. So they looked at 7 million flights and about 12,000 emergencies. So that's where this 1 in 600 comes from. And the stats that I presented earlier are what happened. Syncope most common. Physicians are the most common responders. And EMS is around 4% as well. Diversion only happens 7% of the time. So a small percentage of the time is actually diverted. And they've got some follow-up data on lots of these patients. Interesting to know that of the 26 patients who went to the hospital via EMS, 9% only were admitted. So even when you divert, a lot of these patients end up not even getting admitted. They go to the ER and then they end up going home. And a small percentage, 0.3%, died. Most common reasons for admission were stroke and OB-related issues. Of the 0.3%, 36 deaths, 30 of them actually occurred during the flight itself. Most common treatments, oxygen, followed by IV fluid and aspirin. Sometimes patients who were nauseated were diverted as well. And then using albuterol nitroglycerin really had no impact on whether or not the patient was diverted in their data. AED was applied to about 137 patients. 40% of them were syncopal, 25% were chest pain. 24 of these patients had a cardiac arrest, and a shock was only delivered in 5 cases, and a person only had ROSC when they were shocked 1 time. So an AED is lifesaver. We saw that in Damar Hamlin on the football field, but on an airplane flight, it's pretty uncommon. So how do you keep all this straight? Well, fortunately, there's an app for that. This app I have absolutely no relation to whatsoever, but I recommend everybody has it on their phone. It's called AirRx, and it essentially has everything that I just went over in this talk. It goes through all the most common issues, how to diagnose it, medical legal issues, all of these different things. So, you know, we're all aware that when we're in stressful environments in the operating room, we can remember a lot of things, but we can't remember everything. So cognitive aids are really helpful and important. And so this is a great cognitive aid to have in your back pocket. All right. So that ill patient is safely back in their hometown. Thank goodness. You were inspired by this really amazing thing that happened on the airplane, and you are ready for your next adventure. And while you're thinking about your next adventure, you're still on this airplane flight, and you come across this article that says, and this article was about a year old, Virgin Atlantic is opening up space tourism sales already. All right. So for the very low price of $450,000, you can get a ticket to go into space now. This is open to anybody in this room. If you want to go to space, you just have to cough up $450,000. So this could be you. You could be flying into space and become the next astronaut. And if you think that this is not real, this is an infographic that's produced by this space exploration think tank that goes over the various potential futures for space tourism. And the scale goes to the year 2044, and there are lots of things. There are already private astronaut missions that are going out into space, barely making their way into space, but they're going out there. Probably in the next few years, somewhere between, this infographic was produced in 2021, so somewhere between now and 2030, we're going to have suborbital tourism. So you're going to go up into space, but you're not going to orbit the whole Earth at this point. But not too far long after that, there'll be high altitude tourism. So these are using these balloons that can go way up into space. Cislunar, this is going around the Earth. Probably somewhere, the expectation is in the next 5 to 8 years that anybody in this room could, with enough money and time, do a cislunar trip around Earth. It's crazy to think about, but that's the direction that we're going. There'll be crewed space station missions where you could go to an international space station or another private space station, probably somewhere in the next 10 years or less. And this is really where a lot of the talk is going to focus now, is that going back to the moon, this is going to we're going to be back on the moon. We, as in humans, will be back on the moon in the next few years, probably. And then the mission to deep space and Mars is not all that far off. Somewhere probably within many of our lifetimes will be there. So anybody heard of Artemis? This is the NASA exploration that is ongoing right now. Their plan is to make it to Mars and have a permanent settlement, maybe also on the moon. And so this is somewhat science fiction, but is actually really being planned. So you decide you're going to go to space, and you're 1 week into your trip to the moon, and this is your co-astronaut Buzz, and he's endeavoring on a spacewalk
to infinity and beyond.
And unfortunately that happened. That's going to hurt. Sadly, Buzz suffers a proximal humerus fracture. And he might need surgery for this proximal humerus fracture. But Earth is really, 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 really far away. How far away is it? So I find this really interesting. When many of us think about space, we just sort of think about it's out there, right? It's not on Earth. It's just like up there somewhere. And the International Space Station is actually not that far away. You can, on a clear night in the right setting, you can see the International Space Station. It's 250 miles above Earth. That's far, but not that far. The moon is about 250,000 miles away. So that's really far. That's why it's so hard to get there, and that's why we haven't gone back. Mars is 300 million miles away, and that's the next closest planet. It's scales of magnitude further away. So Buzz is out there, you guys are on Mars, and you have to think to yourself, are you going to stay? Are you going to stay on Mars and take care of him, or are you going to go? And if you think you're going to go, you have to travel at basically the fastest speed possible, and it will take you 7 months to get from Mars back to Earth to get medical care. That's not likely. So if a crew is going to Mars, they got to be self-contained. They got to be able to take care of all this stuff on their own. They have to be resilient. A trip to the moon, best case scenario, is going to take 4 days. That's a significant amount of time as well. Maybe a little bit more realistic, but still a lot of time. There's lots of risks in space. If we're traveling in space, you're likely going out there not just to look around, but you're also going out there to do some extravehicular activities of sort. And if that happens, you might have some traumatic issues, you might have bleeding issues, you might even have some infection. Yes, there are ways of getting infection in space. And there's some other odd things that happen in space too, like radiation and meteoroids and interplanetary dust, all these things that we don't really think about on Earth. Oh my gosh, what happened? Sorry, I'm not sure what happened here. All right. So, yeah, if you're out in space and you're doing these extravehicular activities, there's lots of potential dangers you might expose yourself to. The lack of gravity varies depending on where you are. If you're on the moon, it's actually 1/6 the gravity of Earth, but in Mars, it's only 1/3 of the gravity, which has some implications regarding the specific risks. Weightlessness will reduce your bone density and will lead to osteoporotic changes in just a few months. And if you're going to Mars, you're going to be out there for several months. So there's lots of different factors to consider. How are you going to evacuate somebody? Are you going to evacuate somebody? Is telemedicine available? And if it is, how effective will the telemedicine be? Let's say you have to provide anesthesia and do surgery. How are you going to do that out there in the middle of the space planet you're on? And there's some behavioral health issues to consider as well, like our ability to recall facts and do things degrades over time, especially if we're not doing them frequently. So you need to match, when you're thinking about the equipment you're going to have on board, you got to match the equipment to the skill set of the people on there. If you bring a Bookwalter retractor set on board and nobody knows what the heck this thing is, you're not going to be able to do much with it. So you really have to match the skill set to the people that are there. The weight considerations, the volume and the size of the equipment has a big issue to consider, as well as the power requirements. There's not an unlimited power source out there, although solar power is probably quite effective. And you got to think, how are you going to support the use of this equipment? Are you going to have to clean it? Are you going to have to repair it? Are you going to need to do things like laboratory work or have some imaging guidance while you're doing your procedures in space? You could potentially bring a kit up there and resupply the kit if you're on the moon. It would take several days. It's not impossible, but it's something that could potentially be done. A resupply of a kit on Mars is essentially impossible to make it all the way out there. The drugs will degrade as they get into space and as time goes on. But on the International Space Station, they resupply all the time. This figure here basically shows how they send up these ships and they rendezvous with the International Space Station and they resupply it all the time. That's how these guys and girls who are up there for months or years at a time are able to do that. If you're in space, the most likely helpful diagnostic modality for imaging is going to be ultrasound. And ultrasound is definitely sort of like the wave of the future, not just in anesthesiology, but in emergency medicine and internal medicine. And so this will be used on board for sure for both diagnostic as well as procedural guidance for any type of procedure that might need to be done. The best profile for a physician or a crew medical officer for a mission would be somebody who has some emergency medicine background, maybe some wilderness medicine skills as well, has some minor surgical skills in critical care medicine. And this person may need to serve both as the surgeon and the anesthesia provider if they are needing to do the procedure. It doesn't necessarily have to be a physician, but likely it would be a physician. Telemedicine. This relies upon a remote form of communication, and a lot of us probably started doing telemedicine in the COVID pandemic. We, in our pre-op clinic, had switched completely to telemedicine. Now we've kind of pivoted back again. And telemedicine is great to communicate with people remotely, but there is a latency to consider. So if you're on the moon and you're providing some sort of telemedicine, there's going to be about a 2-second delay from the audio and the video to go from the moon back to Earth. But if you're on Mars, that latency is going to be about 4 to 20 minutes. So different considerations depending on where you're going to be providing this care. So here's a really interesting example about telemedicine actually already used in space. There were these scientists who were on the International Space Station, and they were doing blood flow studies. They were using an ultrasound, and they were scanning the internal jugular vein, and they found a clot on one of the astronauts' internal jugular vein. He didn't have a bleeding disorder known before. And so what they did is, here, this is the timeline of what happened. They found a thrombosis found on physical examination, and they actually called a hematologist. This happens to be a guy that I work with. His name is Stefan Moll. He's a hematologist at UNC. And the first thing he said when they called him is, "Can I go see my patient?" He asked if he could be sent to the International Space Station. And of course they said no, that would not be possible. And so this was within 24 hours. They consulted him and they went ahead and started him on Lovenox. And then at 41 days on this International Space Station, they were able to rendezvous and they provided him with some apixaban. Based upon the diagnosis, he continued to ultrasound himself. And the decision was made to discontinue the anticoagulation for re-entry into Earth. And when he landed, the clot was gone and they stopped the anticoagulation. So pretty cool story about using telemedicine in space. It really does work. And it has some nuances, of course, but it's a cool real-life example. So anesthetic and surgical considerations. How are we doing on time? Doing great. All right. So the blood flow to your body changes depending on whether you're in the spaceship, if you have gone into microgravity, and when you return to microgravity. So normally when we're standing, our blood pressure in our head, mean pressure standing is about 70. Mine's about 70 right now, and in your feet it's about 200. When you go out into zero gravity, it redistributes, and the blood pressure is roughly the same everywhere. And then when you get back into the gravity environment, normal gravity post-flight, there's actually these quite significant fluctuations to where you only have about a map of 30 or so in your head. So if you're standing right after the space flight, you're going to be quite woozy. And so you have to think about the hemodynamic fluctuations that occur both in microgravity and returning from microgravity. There's a lot of people who think you can't get bacteria or infections in space, but they've shown that bacteria can grow, and you can understand why the circumstances would occur where infection and sepsis might happen. You're confined to these small spaces. The ability to clean yourself is quite limited. Here's a picture of an astronaut giving herself a bath. It's just these basic bubbles of water and soap that they smash on their body and rub around and try to clean themselves. And so there's altered immune function, there's an increased risk for bacterial growth, and it's quite the bad circumstance. So fortunately, no anesthetic has been provided during a space flight yet, but there is likely going to be a circumstance in the near future where this might occur. The general approach is to think about the patient's condition, what is the experience of the provider on board, how urgent is it, what's the NPO status. And so what you should do if you're planning a space flight is to think about what's the worst case scenario and plan for that. So you should plan for it to happen to where maybe it's the medical provider who's actually going to have to need the medical care. And so somebody who doesn't have medical expertise is providing care. They're severely deconditioned, they're hypovolemic, they're hard to intubate, and they've also been eating and they have a full stomach. So if you can, regional anesthesia should be attempted first. There's some pre-flight training that could be done using telemedicine. There can be some just-in-time training that can improve the chance of success. If regional anesthesia doesn't work, then IV sedation for peripheral surgery and trunk surgery may happen. And GA should really only happen in the most extreme circumstance. We have no other options. And if you're going to do general anesthesia, TIVA is really the way to go. Inhalational anesthesia is not necessarily going to be a safe thing to use in an enclosed environment. And when you're doing TIVA, you still have to consider the flow dynamics. So you're going to have a pump that's going to have to overcome the microgravity issues and think about how perfusion is going to be altered in your patient. You should only perform surgery if it's absolutely life-saving. So uncomplicated appendicitis, for instance, can be treated with antibiotics. And other temporizing measures can be used. The temporizing measures that you use, though, you need to think about how difficult is it to get this patient back to Earth. So there's a picture of the astronauts getting back into the capsule that takes them back to Earth. You can see they're in a sitting position. So if you had like a femur fracture, it's going to be pretty hard to get somebody to sit into that position as well. So you got to consider how you're going to get them home. Lots of unanswered questions that still need to be answered in this area. For instance, should the crew all have the same blood type? Should that be a requirement for deep space so that they can transfuse themselves? In the future, we may have 3D printing and be able to generate IV fluids. That will change some of the supplies we need to take. There was the question that was posed to astronauts, is it worth it? If you went into space and a medical emergency happened, would you actually want us to do anything about it? Would you want us to treat you? And they all unanimously said yes, so they want to spend the time to train for that. Should prophylactic procedures be done? Should we take out all their appendixes before they go out into space and do some prophylactic surgery? It's kind of extreme, but maybe that's the right thing to do. And astronauts are really smart people. They can learn a lot. They can learn really fast. I bet they can learn all this stuff, most of them, that we do. And AI. Anybody heard about the advances of AI the last couple of months? It's like scary what's going on out there. But AI is likely to revolutionize the way in which we need to prepare for space. I've got about 5 minutes, and I'm just going to briefly mention back pain. This was a great review article on anesthesiology. Every astronaut that goes into space will likely develop back pain of some sort. And there's a variety of different reasons, but usually it's self-limiting and will resolve on its own. This is just a great table in this anesthesiology review article from last year that talks about all the different types of back pain that might occur, and space adaptation back pain is the most common thing that will occur. And if you're the treating physician on board, the things that you should do for this type of pain is to do a thorough history and physical, use some basic first-line medications like NSAIDs. There might be muscle relaxants on board if the patient is having muscle spasms, and some position changes and aerobic exercise. And it will resolve usually within a few days meaning like a week or so. But you can have all different types of pains like factogenic or discogenic or deconditioning back pain, myofascial pain, or even a herniated disc from an extravehicular activity. So that brings me to my take-home points. So again, medical emergencies, these are not that uncommon, 1 in 600 flights. So, if there's, let's say, a few hundred of us here at the meeting, there's a chance that everyone going here and going back, one of us might incur a medical emergency. Most commonly, it's syncope, followed by GI and respiratory. You are protected by the Congressional Act from 1998. So the Congressional Act of 1998 protects us in these circumstances for emergencies, not for non-emergencies. There is a kit on board. The kit might be limited, but take a look at the kit, see what it's in there, and request additional materials and help from the ground-based support. Space exploration. It seems like it's far out in the future. It's not that far into the future. These guys over here sitting at this table, I bet in their lifetime, when they become anesthesiologists like their dad right there, one of them might be out in space providing care to a patient and doing some anesthesia. And this might be accomplished through telemedicine, ultrasound, but I think other things like artificial intelligence are really going to make their way on board. And so I thank you guys for your attention. And if anybody's interested, Google spaceman and Elon Musk, and you'll find out a really interesting story about this car that's floating around space with a spaceman sitting in it. So thank you very much for your attention.
All right, thanks so much, Dr. Isaac. That was a wonderful lecture. We're running a little bit short on time. We have time for just a couple of questions if you can come up to the microphone.
Like a very interesting talk. I also have a friend and a colleague on her way to Thailand about 2 months or so ago.
Yeah.
Confronted with a patient that arrested.
Wow.
They ended up diverting the flight to Canada. The complaint she had was that the only tool they had for respiration was a mask.
Oh,
no
yeah.
ambu bag,
Wow.
she said on the flight. So I'm not sure if you're...
Yeah.
something.
Yeah, not required. Those masks, it's a good point, are mouth to mask, and you're going to be providing an FiO2 of about 19%, roughly. That's what your FiO2 is when you're breathing out of your mouth. And so that helps with some degree of oxygenation but not a significant amount. But there is oxygen on board. You could probably entrain the oxygen tubing into the mask and create a seal around the oxygen tubing and try to create a more oxygen-rich environment. But yeah, that's crazy. My friend that was flying to Thailand, he had taken an Ambien, and so he did not respond. So that's another inside pro tip. If you've taken an Ambien or a sleeping aid, don't let your spouse raise your hand because you are an impaired provider at that point. Thank you for your question.
Just real quick, you did a great job about the air flight issues. I just want to mention also, I've been told by other people that even if you do nothing, just your medical knowledge can be very helpful. So for medical students in our midst, for example, just understanding the language and being able to communicate with the ground is very valuable.
Yep, absolutely. Yeah, understanding just the transmission of information is helpful. I talked about cognitive aids a few moments ago. One of the things about cognitive aids is just having a reader that can really help the implementation of cognitive aids. So somebody who can read the app out to the person who is taking care of them, and a medical student or anybody with that knowledge could be involved. Thank you. Yes.
Thanks. Great talk. So I had a Singapore episode, and my flight didn't have a glucometer. So I asked the crew if we could ask if there were any diabetics on board, potentially use theirs. They told me no.
Oh.
So I wondered if the FAA had any stance on that you know of.
The crew said that you were not allowed to?
Yeah, they said I couldn't announce overhead, does anybody have a glucometer that we could use?
Yeah, that's a great question. I don't know if you're allowed to solicit from the airplane if there is a problem with it. If you did it on your own without asking for permission, sort of like do first, ask for forgiveness later, it would probably be fine. But that's a great question. I don't have the answer to that, but I'll definitely look into that. Appreciate it. All right. Well, thank you guys. I really appreciate it. Thank you coming out this morning.